So I'm going to just give a few introduction on this webinar. First of all, I'd like to say Happy New Year with the year 2025. I wish you a beautiful year ahead. And this is the first webinar in the GM Fellowship Program in this new year 2025 here. I'd like to welcome all our audience worldwide, and I invite you all to always meet and exchange knowledge with field experts from all over the world. I invite everyone to register via the World Kidney Academy platform, which is easily accessible and highly enriched with scientific materials. And you can now find many sources which can enrich your vision and your learning throughout a very rich journey. You can find the learning sources with MCQ that test your knowledge on each topic, journal clubs which expand your knowledge every week with 1 or 2 state-of-art articles, and case scenarios where it's a good opportunity to test your problem-solving skills and be engaged in discussions and assimilations of new ideas. And beside all of this, the case scenarios will give you good opportunity to go through further complicated steps with knowing about clinical presentations, the laboratory workup, and histological examinations, and others. And it's an opportunity to have live interactive webinars with a great expert in the field from all over the world. By the end, we have exams and multiple quizzes that test your knowledge and train you to improve your studying and performance. So let's take just very easy sample or test of this. We have a 45-year-old man who has recently diagnosed with Burkitt's lymphoma and initiated chemotherapy. He has a baseline creatinine of 10 micromole per liter. You have been consulted as his creatinine has increased to 200. And you review his urine microscopy, and the following is observed. Please look at the screen and send your questions to the chat box. What type of crystals are identified on this microscopy? Is it calcium oxalate, uric acid crystals, triple phosphate, cysteine, calcium carbonate? Yes. Here we have uric acid crystals. We can see different formations of uric acid crystals in the figures. We have rosette, hexagonal, and diamond-shaped crystals, which cope with uric acid crystals. If so, the same patient, unfortunately, after 2 days, develops oliguria. His creatinine worsened. The table now demonstrates his biochemical finding. His creatinine is now 4.3 milligrams per liter. The phosphate is 6.2. Calcium is 1 milliequivalent per liter, and potassium is 6. The LDH is 500. So what do you think is the likely cause of this electrolyte disturbance? Could it be due to hemolysis, acute tubular necrosis, drug toxicity from the chemotherapy drugs, pancreatitis, or tumor lysis syndrome? The patient has high serum creatinine, yes, but there is well hyperphosphatemia. Calcium is low, there is high potassium and high LDH. All these copes with a diagnosis of tumor lysis syndrome. Remember that the patient has Burkitt's lymphoma and has already started chemotherapy, which may have contributed to this condition. So the patient is found as well to have a uric acid of 15 milligrams per liter and high uric acid. What do you think is the pathophysiological mechanism responsible for this abnormal level? Is it due to overactive xanthine oxidase, reduced purine synthesis, elevated uricase activity, or is it due to impaired excretion of uric acid by the kidney or decreased purine salvage post-Y activation? We have a patient with Burkitt lymphoma, a picture of tumor lysis syndrome after chemotherapy, and the correct answer will be impaired excretion of uric acid by the kidney, as there is a rapid release of intercellular components with a progression into tumor lysis syndrome, and this will all overwhelm the excretory capacity of the kidney, leading to hyperuricemia. So as a part of the workup of the patient has this ACG. Please has a look. Find abnormality. What abnormality can you see in this ACG? Is it prolonged QT, T-wave change in the inferior leads, poor airway progression, ST segment elevation, peaked T-waves? Yeah? The correct answer would be prolonged QT interval. And accordingly, what is electrolyte disturbance leading to this abnormality in the ACG? This prolonged QT interval is due to hyponatremia, hyperuricemia, hyperphosphatemia, hypocalcemia, or hypomagnesemia. Yeah? Yeah, this patient with tumor lysis has hypocalcemia, and hypocalcemia can lead to severe manifestations, severe form, including tetany seizures and hypocalcemia, prolonged QT interval. So if immediate interventions are gonna start for this patient, hydration, aggressive hydration has already started, and uric acid, unfortunately, continues to rise. So in this scenario, which therapeutic option would be most appropriate to reduce uric acid levels? Is it furosemide, rasburicase, allopurinol, colchicine, or kidney replacement therapy? Yeah, the correct answer would be rasburicase. I think we're gonna learn about it in this webinar, and I hope you make the most of the webinar. Thank you for your attendance, and just mark your calendar for the ongoing events for the year 2025, and thank you.
Thank you so much, Professor Rasha, for this nice demonstration. And I'm going to share my screen with you and show more things about our exciting fellowship. Thank you so much, everyone, for making it to our webinar again today. And this is our first Onco-nephrology webinar among a series of the GN Fellowship. And I'm very excited to have this panel of expertise. We have Professor Nicci Wearne, Professor of Nephrology in Cape Town University, South Africa, Professor Saddam Hassan from UK, Professor Rasha Samir from Egypt, and our guest speaker is Professor Edgar James. And we have also Professor Yara Moheb from Mansoura, Egypt. And our expertise today and guest speaker is Dr. Edgar James. He is the Chief Renal Service at Memorial Sloan Kettering Cancer Center. Here is our agenda today. And the main talk will be about the GN among cancer patients and updates on onconephrology. Dr. Yara Moheb is going to present a case, and Dr. Saddam and Dr. Nicci is going to moderate the discussion. And again, we just congratulated our 2024 fellows who were graduated last month, and we are starting another cycle of the 2025 fellowship. Here is our GN Fellowship Board. We have great expertise from all over the world. I'm the program director. Professor B.R. Ronco is our honorary board advisor. Professor Mohammed Sabh is our academic director. We have Professor Bayanika Davidson and Nicci Wearne from South Africa, Professor Rasha Samir from Egypt, Professor Manish Rathi from India, Professor Mushtaba Qadri from Pakistan, and Professor Armila Ananda from India. And our 2025 fellowship starting in 2 weeks, so February 3rd, and the door is still open if you haven't applied yet. Why did we choose to have 3 modules, 16 weeks each, for this GN education because this is not based on webinars or seminars or single-sided or one-directional education. It's not based on monologue, but dialogue, and we love to see our fellows engaged in our program. So we offer them a lot of scientific materials, including clinical case scenarios, lectures, journal clubs, and MCQs. They are not really for assessment or evaluation, but they are educational MCQs, because when the fellow submit their answer, they are going to receive the correct answer with a detailed explanation. So it's we'll teach you how to do a critical thinking and critical appraisal and brainstorming in the GN field. And as you can see, we are gathering expertise from all over the world to teach you how to deal with the challenging cases of GN. We are using a smart platform, and all activities and assignments are monitored in the platform. All the materials are released on weekly basis. So every Monday morning, there will be new scientific and educational material released to you. You will have your username and password, and you will have the freedom throughout the whole fellowship to go over these materials, but you need to submit your tasks and assignments before the end of each week. Here is module 1 timetable. We are going to start with the first week of approach to glomerular disease, then nephrotic versus nephritic syndrome. Then we'll have dedicated week for nephropathology. Then we'll focus on podocytopathy, including mechanism of glomerular injury, minimal change disease, FSGS. Then we'll move to membranous nephropathy, diabetic kidney disease, IgA nephropathy. And before we finish each module, we have 3 weeks of exams. Then module 2 will be focusing on secondary GN. We'll start with, again, nephropathology week, then lupus nephritis, ANCA-associated vasculitis, infectious-related GN, GN in pregnancy, GN in onconephrology, amyloidosis, February, and immune tactoid GN, MBGN, and C3 glomerulopathy and cryoglobulinemia. The last module will be focusing on challenging situation in GN. We'll start with hereditary nephritis and the role of genetic testing in GN, then post-transplant GN and the recurrent GN after kidney transplantation, TME. Then we'll wrap up with lessons from treating GN patients. We'll focus on immunosuppressive medication, especially the novel ones in the GN, role of plasma exchange, and the pipeline therapeutics. Then we'll have the final exam. If you haven't joined us yet, and if you are interested, please do. And here is our gift for you. We have a promo code, so you can get 10% discount if you use this promo code. If you can also scan the QR code, so promo code of early 10 gives you 10% discount, and this will be expiring in 2 days from now. Again, all the knowledge that we are providing, the aim is to improve our standard of care, because the great aim of education is not the knowledge itself, but the action, and knowledge has no value except we put it in clinical practice. Thank you so much, and I will let Professor Rasha Samir, the main organizer of our meeting, to moderate the session.
Thank you so much, Dr. Amr. I'd like to invite Dr. Saddam Ahmed to introduce Dr. Yara Moheb, who's going to present a case.
Thank you very much, Dr. Rasha. Thanks, Prof. Amr, for inviting me to join this distinguished panel. I can see that it's quite intense and insightful program that you have shown there. It's my pleasure today to be joining in this important emerging theme in the glomerular disease with regards to how to manage patients in the context of malignant disorders. It's quite a challenging disease in the sense that the knowledge is emerging, the landscape of treatment is expanding, and I'm sure that Prof. Edgar will update us on that later. So I think it's a fantastic setting to have a clinical case presentation first, just to show how complex the management of such cases are. And then at the end, we will have the insights on the management of novel anti-cancer drugs in the setting of renal disease with Professor Edgar. Dr. Yara Moheb has a special interest on onconephrology. It's quite complex and quite challenging area. And I understand that she has a clinic with a special interest dealing with cases with complex onconephrological problems. It's my pleasure to introduce Dr. Yara Moheb from Mansoura University.
Thank you, Dr. Saddam.
Thank you very much, Dr. Rasha.
The screen now is ready.
Yes.
Our case started in April 2023 with a 39-year-old Egyptian female housewife with no special habit of medical importance, was referred to Mansoura Oncology Center from Internal Medicine Department. 2 weeks before, the patient was admitted for progressive dyspnea and discovered to have AKI with serum creatinine 14 milligram per deciliter, normocytic normochromic anemia at hemoglobin 7.8 gram per deciliter. The patient underwent hemodialysis and renal biopsy was done, and the biopsy showed myeloma cast nephropathy, and the patient was referred to the oncology center on maintenance hemodialysis. At diagnosis, the bone marrow aspirate was hypocellular with plasma cell infiltrate about 36%, and the whole body CT showed scattered ill-defined small osteolytic lesions. The plasma protein electrophoresis showed monoclonal band at gamma region with plasma cells expressing CD 38, 138, and 56 with negativity for CD 19, 20, and 117, concluding a case of multiple myeloma. On that basis, the patient started her chemotherapy in May 2023 with cyclophosphamide, bortezomib, dexamethasone. She completed 8 cycles by May 2024, and her follow-up showed partial remission with plasma cells 15%. Plasma protein electrophoresis still had monoclonal band at gamma region. So the patient in June 2024 started her VCD protocol, and her follow-up in August showed complete remission with plasma cells less than 2% with normal plasma protein electrophoresis and the negative Bennstrom's protein. In June 2024, the patient was referred to the Onconephrology clinic from bone marrow transplant clinic for evaluation, and the patient was in remission, candidate for hematopoietic stem cell transplantation. The examination was unremarkable. Blood pressure was 130/80, and good urine output, no uremic manifestations. Serum creatinine was stable around 4 milligram per deciliter before and after the hemodialysis sessions. So the patient was advised to stop her hemodialysis and follow up at the Onconephrology clinic. We revised her serum creatinine along the course of treatment. You can see that she started dialysis at the point of 15 milligram per deciliter of her serum creatinine, and then she started her chemotherapy. Serum creatinine decreased till 4 milligram per deciliter. She stopped the dialysis, started her VCD protocol, and serum creatinine showed slight decrease to 3.6 milligram per deciliter and became stable, and this may correspond to being in complete remission. So at follow-up, the patient was stable, independent from dialysis. Her serum creatinine was stable at 3.6 milligram per deciliter with estimated GFR of 18 milli per minute by CKD-EBI equation. She was referred to the bone marrow transplant clinic as no contraindication for hematopoietic stem cell transplantation from nephrological point of view. But unfortunately, dialysis is not available at the bone marrow transplant unit at Mansoura Oncology Center, and the team was worried from the renal point of view, and the patient was to be excluded. So at this point, we decided to do a rebiopsy for prognosis and whether this kidney would benefit from bone marrow transplantation or not. And the biopsy showed MPGN pattern with only 2 sclerotic glomeruli, interstitial fibrosis about 40%. So although it is an element of chronicity, there is still a hope. So we defended the kidneys through discussion with bone marrow transplant team with the following recommendation: kidneys hopeful and shall benefit from hematopoietic stem transplantation. Chemotherapy doses should be adjusted according to the estimated GFR by CKD ABI equation. Good hydration before, during, and after hematopoietic stem transplantation is mandatory. Follow up with the onconephrology team during the journey for close monitoring of kidney function is mandatory. Patient may need dialysis at any point. And the good news that under the supervision of Mansoura Nephrology and Dialysis Unit, we are preparing a portable hemodialysis unit at the bone marrow transplant isolation ward for this case and similar cases. So let's go through a rapid discussion for this case. First, what are the current guidelines and if it is sufficient? The second point, what about the same cases in literature? And the third point, how can we change practice? If you go through the National Comprehensive Cancer Network guidelines for multiple myeloma, you will not find any specific guidelines for the kidneys. The same with the European Hematology Association and European Society for Medical Oncology, although kidney impairment is the main direct cause of early mortality, along with infection in multiple myeloma patients. About the KDIGO 2021, you can find these recommendations in the MBGN chapter: complete evaluation for hematological malignancy or plasma cell or lymphocytic disorders. Working with hematologists is important because a number of the drugs used are not commonly used by practicing nephrologists, with no specific recommendations for treatment regimen or mentioning bone marrow transplantation as an option for the kidneys. But what about the published articles? This article published in 2024 in the International Journal of Hematology and Oncology showed that 60% of patients became dialysis independent after hematopoietic stem transplantation. Another article published in the Transplantation and Cellular Therapy Journal showed that among the 27 patients who were dialysis dependent at the initiation of treatment, with their mean baseline GFR around 10 milli per minute, 18 of these patients were no longer dialysis dependent. 8 before bone marrow transplantation, and 10 after the autologous stem cell bone marrow transplantation, and the 1-year cumulative incidence rates of dialysis independency and achievement of renal benefits were 66% and 52% respectively. In this article, you can find that there was a significant improvement in renal function at 1 year post-transplantation, with 2/3 of the patients became dialysis independent. Even 4 of them went successfully into their renal transplantation. So this allowed the introduction of renal transplantation as a viable treatment option in patients with multiple myeloma who are in complete remission after their induction therapy followed by bone marrow transplantation. It's time to change practice from the old practice that the nephrologist can suspect multiple myeloma, doing renal biopsy and directing the patient for chemotherapy, follow up the kidney when the insult occurs, or which depends on the timing of referral from oncologist, to that the nephrologist can suspect multiple myeloma, do renal biopsy to diagnose, direct the patient for chemotherapy, modifying the dose and the regimen, and follow up the response, follow up the kidney, managing kidney impairment due to other causes as renal causes, doing renal biopsy for prognosis, and directing the patient for bone marrow transplantation for the favor of the kidney. Finally, onconephrology practice is not a matter to treat. You should screen, prevent, detect, of course, to treat, and follow up is a cornerstone in onconephrological practice. Thank you.
Thank you very much, Dr. Yara, and congratulations for this timely and amazing management. I want to congratulate you first for the collaboration with your colleagues and oncology and being enthusiastic and defender for the kidney, obviously. It's quite a challenging scenario. I just want to highlight some of the issues that we have here in the UK in such kind of discussions, and I would encourage anyone who have any questions to submit them. You rightly mentioned that the kidney function was estimated by EGFR, and the equation was CKD-EPI, which I think is the most convenient in terms of drug adjustment in cases of anti-cancer drugs. And this has been even echoed by the KDIGO guidelines in 2020 for anti-cancer management. That's an important point because in most of the other scenarios, we would use the Cockcroft here in the UK. And I think worldwide, we use the Cockcroft formula to adjust the drugs. The problem with malignancy is that patients have an element of sarcopenia. This might mean that they might be underdosed in terms of anti-cancer treatment, which might decrease their chance of responding to the treatment. So I'm happy that you have used the CKD-EP equation for that. The other point with regards to the kidney function, I guess the proteinuria, and the classic teaching has been always, whenever you see just less than 10% albuminuria in the total proteinuria, this is highly likely to be myeloma, which is right. However, with the expanding spectrum of myeloma presentation in the kidney, it might be even the majority proteinuria as well, because such as in your case, PGN and MID can have lesions, quite glomerular lesions, and it might be the majority might be proteinuria, not only albuminuria. The other point that I congratulate you for is the kidney biopsies. People would be reluctant to sometimes biopsy patients and with myeloma for fear of bleeding. I think those fears are not justified, especially if, as you did in your case, that will change the management decision. So in the first time you biopsied your patient, he was in the setting of acute kidney injury. And in the second time was to assess for the benefit of going for stem cell transplant. So again, I think that was quite justified. And I think it added information to the management, and it might make the oncologist more confident to offer sort of other immunosuppression. The third discussion that we have here always all the time in the UK is the extracorporeal removal of the free light chains in the setting of myeloma. There was some studies with regards to plasmapheresis, which were not quite convincing, to be honest. And I think the Plasmapheresis Society has plasmapheresis as category 3, which is quite weak evidence. However, there was some interest at certain point in using high cytokine output membranes. There was a study here in Birmingham, the EU-LIGHT study, which showed a limited, maybe renal benefit. However, the overall survival didn't change much. And the thought was maybe the high cytokine output membrane is removing free light chains, but at the same time removing much albumin and can cause troubles with the antibiotic adjustment and anti-cancer management. So what we do offer here in the UK is to try to dialyze those patients whilst on dialysis as frequently as we can, make sure that they are well hydrated. And obviously, if centers can provide sort of medium cytokine membranes, that would be okay. The thought for high output membranes is vanishing more and more, and it's class B in terms of most of the recommendations, so it remains an individualized process. And the last point I want to as well highlight here in that context is the management of anemia in the context of malignancy, because there was some concern with regards to administering erythropoietin stimulating agents to patients with malignancy. And the thought is, I think from the systematic review, if the patient is under active chemotherapy, then still erythropoietin might be a safe choice. Especially if patients are planned for transplantation in the future, you want to try to avoid allosensitization as much as you can. So I think the epidemiology on the safety of the erythropoietin stimulating agents in the setting of malignancy is changing, and people are looking carefully, especially with the advent of the new HFpEF factors. So we were waiting for the outcomes of those agents. But once again, very well done, and I'm happy that your patient is improving, and thank you very much for sharing your thoughts with us today.
Thank you, Professor.
Thank you very much, Prof, for the explanation and for the case presentation. I think it sets the stage very nicely for the discussion that we'll have from Prof. Edgar James. So Prof. Edgar James really will discuss important updates in onconephrology, a really growing area of nephrology. He's a renowned nephrologist and chief of the renal service at Memorial Sloan Kettering Cancer Center in New York. So very well placed to give this discussion. He has a very distinguished career focusing on kidney complications in cancer patients. He has contributed extensively to advancing our understanding of nephrotoxicity from cancer therapies and improving kidney care in onconephrology. His presentation will highlight emerging research, challenges posed by novel cancer treatments, and strategies to try to optimize kidney health in this unique patient population. We're very grateful for him being here today to share his expertise with us, and I'd like to wish him well in his presentation. So I'll take it. You can hand the floor over to Prof. James.
All right, so I think we are ready, right? You can see my presentation, I think.
All 100% there, Prof. Thanks.
Okay, all right. All right, so again, thank you for the invitation. And I want to thank the World Kidney Academy as well as the organizers for the great invitation from Chile, New York. It's been really cold these days, so I wish I could be there in person and not here. And so what I'm going to do in the next 25 minutes is give an overview of glomerular diseases in cancer patients. It's an overview. I mean, we could spend hours talking about every single topic that I'm going to touch on today. It's something that we see here every day. Our practice is pretty much 100% onconephrology. This is what we do for a living, pretty much. And it's becoming more and more challenging as new medications are available. Our patients are living longer, and new issues come up. All right, so let me see, this is not advancing. Let me see. All right, so basically, glomerular diseases in cancer can be pretty much divided in two big groups. So those that are linked to therapy, like the ones here on the right bottom, chemotherapy, immunotherapy, targeted therapy, or transplant-associated glomerular diseases, also as paraneoplastic glomerular diseases. Now, what we see at our institution is that every single patient that comes to MSK already comes with a cancer diagnosis, so that is a little bit different to a conventional nephrology practice in which the initial presentation may be the renal disease, and then from there you go backwards to try to figure out what's going on. What we see at our institution is more the opposite. The patient comes already with a cancer, and then they realize that there are some kidney issues, in particular, for example, proteinuria. So what I'm going to do is I'm going to touch on these two main categories, paraneoplastic glomerular diseases, as well as therapy-associated glomerular diseases, which is probably a big chunk of our practice, and probably in terms of numbers, higher numbers compared as paraneoplastic, at least at our center. And so paraneoplastic glomerular diseases. So I would like to start with a case. This is a real case from our institution, seen by one of our attendings. So a patient who presented to MSK with a thymoma, and then it was found at the time of the initial evaluation that the patient had a proteinuria, stage 4 thymoma. The patient underwent therapy with cisplatin, cyclophosphamide, doxorubicin, followed by radiation and resection, everything going well. And then the patient presents 5 years later with AKI, hypertension, urgency, and new onset edemas. The proteinuria, there was more than 300 in the UA. There was also some RBCs. The 24-hour proteinuria showed that the patient had around 6 grams of proteinuria. All the serology were negative except the complement that was low. And the biopsy showed MPGN. The patient was started on CellCept, prednisone, and Plaquenil. However, didn't have a very good response and progressed to ESRD and ended up on peritoneal dialysis. On the right, we can see the histology of this particular patient was the EM that was consistent with MPGN. Another case, this is a patient with a CLL that presented with a nephrotic syndrome. So the patient has CLL, stage 2, no therapy. A new patient to our institution presented with edema, fatigue, cold urticaria, and arthralgias. The initial creatinine was normal, a little bit of hyperbuminemia. Cryos were positive, and the UA showed some hematuria, or some positive for him, and significant proteinuria. And the biopsy showed a cryo-GN with a couple of glomerular crescents and deposits of monoclonal IgG lambda. The patient was started on rituximab and cyclophosphamide, complete remission, and then had a relapse a few years later that again showed cryo-GN type 1. The patient received therapy with rituximab ×8 plus venetoclax with complete remission. On the right, so we see the in the middle panel the changes of the crescents, and on the right the IF showing the IgG lambda deposits, and on the left the EM of this particular case. So cryoglobulinemia, like the case that we saw in this case, so there are two or three different flavors: type 1, type 2, and type 3. Type 1, like the one that this patient had, is monoclonal, more IgM, IgG than IgA. The mixed cryos, usually associated with infections. It can be also due to lymphoproliferative diseases or immune diseases, or essential mixed cryoglobulinemia. And in the case that we discussed, basically it had a type 1. And so in general, we can say that the types of glomerular diseases linked to paraneoplastic syndromes are, it could be membranous nephropathy, which we see sometimes, often linked to solid tumors, especially lung and colon cancers, but it can also be things like thymoma, for example, minimal change disease that we see occasionally linked to Hodgkin's lymphoma, and MPGN usually associated with things like CLL. And what do we do for these patients? So number one of the main things is to identify what is the reason for this. So if the patient presents to a renal clinic with a proteinuria, and then we do the workup, and we determine, for example, that the patient has membranous nephropathy. So really, in that patient, we need to make sure whether or not this is a primary membranous versus secondary membranous, and therefore a comprehensive evaluation to detect associated tumors is going to be indicated. That will include imaging studies as well as lab tests for tumor markers, etc. If the malignancy has been identified, so the main thing is going to be to treat this particular patient: surgery, chemotherapy, radiation, depending on the cancer type and stage. And we as nephrologists, so we will manage some of the symptoms associated with the problem, with the nephrotic syndrome, including the use of diuretics, albumin replacement, if there is severe hyperalbuminemia, as well as antihypertensives, in particular using ACE inhibitors, and low salt to help control the edema, and the appropriate protein intake to help with the hyperalbuminemia. Like I said at the very beginning, in our case, in our institution, what we see more often is the patient that comes first with the malignancy and then develop the proteinuria. I had another case recently. There was a patient with a lymphoma. Again, same situation: lymphoma, membranous nephropathy. And what we did, or what the oncologists did, was to treat the lymphoma. And as soon as the patient had a response, the proteinuria went away, and the patient did well. So again, I want to underline that in this particular case, we were thinking about a paraneoplastic syndrome. The idea is to first to treat the underlying disease, and that usually leads to an improvement of the kidney issues, although not all the time. And in some cases, like in the first case that I showed, the patient may end up on dialysis and not have a response. All right. So a situation that we see often at our institution, and that is a common problem, and is the issue of a post-transplant glomerular diseases and proteinuria. And it's a big problem. And we have published previously that, at least based on our series, close to 60% of our patients at MSK who undergo an allo stem cell transplant will develop some degree of kidney dysfunction, AKI or proteinuria or some sort of complication. Is a very common cause for consultation to our service. And sometimes we don't know, I mean, it's difficult to pin down exactly what's going on. In this particular case, I'm going to focus mostly on the issues associated with proteinuria. So this is from one of our papers, and showing what happens when you undergo an allo transplant. So number one, of course, there is a lot of the conditional therapy that happens before the transplant. And so that will include chemotherapy plus, in some cases, radiation as well. And then the patient start getting different things. They get infection prophylaxis, so antibiotics, antifungals. And all of these can lead to issues initially around the time of the transplant, and the engraftment syndrome that can lead to AKI, and the SOS that also can lead to AKI. Also, this patient can develop a GVSD that can progress to becoming chronic. Many of these patients can develop, like I said before, AKI that can become CKD later on. They also, in addition to antibiotics and antifungals, the patient will receive, all of them will receive, or the majority of them will receive GVSD prophylaxis that most of the time will include a CNI as well as mTOR inhibitor or methotrexate. And these patients may develop during this time, they can develop TMA, for example. And after stopping GVSD prophylaxis, something that we see sometimes is a nephrotic syndrome. And so that can present either as a membranous nephropathy or as a minimal change disease, which are the most common ones. So we see all the spectrum of kidney diseases in these patients from the very beginning until later on. We see proteinuria and kind of a glomerular involvement later on in the game, and usually associated with the patient being stopped the GVSD prophylaxis. This is not our paper, it's from a previous series from another institution. And basically what it shows is that when these patients develop nephrotic syndrome, the majority of them have membranous nephropathy, close to 70%, but also we can see minimal change disease, we can see FSGS, we can see MPGN and IgA nephropathy, but the majority of them will have a membranous nephropathy. And so what happened with this patient? What is done? And so in many cases, patient will receive, for example, corticosteroids. They may receive immunosuppression or receive corticosteroids plus one immunosuppressant. They may receive rituximab alone or be conservative. In this particular ND means that there was no data. And many of these patients will have at least a partial response, as we can see at the bottom of this table. And so basically, when we see these patients and we know that we have in the biopsy, we know that the patient has either minimal change or membranous nephropathy, and often these patients are already off GVSD prophylaxis. So we use either rituximab or we use corticosteroids, and most of the time there is a decent response for these patients, and they do okay. Of course, they have a transplant, so there are many other things going on in these patients, and some of them may not respond completely to therapy, but at least we can rescue many of these patients. Now, one of the questions that comes up, and this is from another paper, and basically in transplant, one of the issues that has come up is whether or not the role of PLA2R, and basically in most of these patients, the PLA2R is negative, and this is a series from the same paper from before, and so highlighting that this is more like present more like a secondary kind of problem more than primary, but there are some cases in which maybe it's primary, but most of the time is a secondary membranous. Something that has been growing recently in the last few years is the potential role of FAT1. FAT1, this is something that was reported by the group at the Mayo Clinic, and basically they took a bunch of patients who had membranous nephropathy that were all PLA2R negative, and in 9 cases were positive for FAT1, and all of them were associated with membranous nephropathy. Were associated with stem cell transplant associated membranous nephropathy. So it seems to be sort of specific, maybe for patients who have a stem cell transplant. And they had also a validation cohort from Cedars-Sinai, which is in LA. And again, 5 cases of allotransplant associated membranous nephropathy all of them again, PLA2R negative, and all the cases were positive for FAT1. So this is something to have in mind. It's not something that we are using as a clinical test quite yet, but it's something that we can send to Mayo to get it tested. But usually, if we have a patient with a stem cell transplant and we have the membranous, we assume that it's related to the transplant, really, you know. But one of the issues with FAT1 is that again, it's increased renal tissues, especially after transplant, correlate with the severity of this disease and lipid metabolism disturbances. And the reason why it's important is because it's possible that this FAT1 may lead to a dysregulation of lipid metabolism, resulting in additional accumulation in renal cells. And maybe there is a role of FAT1 in podocyte injury, and may also influence inflammatory pathways in the kidney, and therefore playing a role in the pathology of membranous nephropathy. So going back at the evaluation of membranous, and so how we evaluate these patients. So like I said, most of our patients already come with a cancer diagnosis, but again, this algorithm here is for any patient with membranous. So basically, we do the initial serology and we do the quantification of proteinuria, and we look at GFR, complement, hepatitis, HIV. We look at the PLA2R, and we do a renal biopsy. And if the PL2R is negative, and the biopsy is also negative, so this is likely secondary, like many of the cases that we see about our institution. And if it's positive, but if there is not a lot of activity, again, the plan with these patients is more of a supportive treatment, basically. Now, if the patient is PLA2R positive, and there is active disease, active PMN, and the proteinuria more than 3.5. In these particular cases, for sure, we're going to start immunosuppressive therapy. And what we are doing these days, most commonly, is the use of rituximab, which makes our life easier to treat these patients, and follow the PLA2R, and if it's positive, maintain immunosuppressive therapy, and if needed, you can increase immunosuppressive therapy. The proteinuria less than 3.5, supportive care in most cases is enough. So for our patients with the cancer and membranous, usually what we do is more of a kind of supportive kind of care. The patient will undergo the treatment of their underlying disease, but in the case of a patient with a stem cell transplant, often we go ahead and give them, for example, rituximab. I just had a case recently, and the patient had close to 10 grams of proteinuria. We gave her rituximab, and about a month later, the proteinuria was coming down. It's already subnephrotic, but it doesn't happen right away. It may take some time, and of course, we added ACE inhibitors, etc. And so this patient may have a decent response if we do that. Something that we see as well a lot is the issue with the kidney injury associated with the use of immunotherapy. As many of you know, immunotherapy is now the first line of therapy for many cancers. And from the kidney point of view, what we see more often is the presence of interstitial nephritis that presents as a picture of AKI. Even in many cases, we don't do a biopsy. We just assume that that's what it is, and treat the patient with corticosteroids. However, something that we see from time to time, and this is a case from our institution. This is the one on top is one of our fellows. He presented this at the ASN a few years back. So there is a patient with a sarcoma who was receiving immunotherapy 2 cycles, presented with edema, dark urine, and high creatinine. And the proteinuria was about 5.8 grams, hyperbilirubinemia as well, some hematuria. And what this biopsy showed, of course, we did a biopsy. This patient the patient had a GN with IgA deposits and some degree of interstitial nephritis. The patient was started on prednisone with partial remission, had a relapse when the prednisone was brought down, and was placed on MMF, and now is doing much better. On the top is the creatinine. So in near presentation, there was some improvement, and then had a relapse, placed on MMF, and the patient is doing quite a bit better. Below, you can see the evidence of the GN by PAS, and at the top left, at the bottom left, you can see the IgA deposits, and by EM on the right, the mesangial deposits consistent with IgA nephropathy. So basically, what I want to highlight is that although in many patients with a immunotherapy-induced AKI, now that we feel more comfortable with this disease, we do not do a biopsy. If the patient has proteinuria, for example, like this case, you have to do a biopsy because you may have something like this. And in this particular case, although this patient was given prednisone, at the end of the day, we ended up doing something completely different. That was MMF. And now with the new therapies available for IgA nephropathy, if the patient had presented now, we may have used something more specific for IgA in particular. We have seen things consistent, for example, with lupus nephritis, and it's something that we have seen cases like that. And in that case, actually, we have to call our rheumatology colleagues to help us out a little bit, because the presentation can be just like lupus, with all the lupus kind of presentation. We have seen several cases like this, like IgA, we saw another case of they was more consistent with minimal change. So it's something that we see, but it is not as frequent as the case of AIN. Now, so this is a meta-analysis. Again, the cases are not many, and therefore, so you have to rely on series from all over the country in order to get enough data. And so basically, there were like two types of presentations. It could be like a nephrotic syndrome or a nephritic syndrome. And the changes consistent with minimal change or FSGS in 24% of the cases, AI amyloidosis about 9%, membranous about 2.2. It can be as a post-immune vasculitis, C3GN, IgA nephropathy, anti-GBM, TMA, immune complex GN, or lupus-like nephritis. So it could be pretty much anything. And the only way to know that for sure would be by doing a biopsy in these cases, and most of these patients, or all of them in this series, had a normal kidney function and then had significant kidney dysfunction. Some of them, about 25%, ended up on dialysis. The proteinuria was pretty much for all of them was in the nephrotic range. And some of them also had other adverse events associated with the use of immunotherapy. And the interstitial nephritis was also seen in many of these patients. So it's something that is, it doesn't come by itself, but often linked to the AIN concomitantly with the proteinuria of the glomerulonephritis. But again, not as common as the AIN. Now, another problem that we see all the time about our institution is the issue of glomerular injury linked to the use of anti-angiogenic therapy. So that we have like a direct line with the oncologists that use a lot of this drug, for example, the kidney cancer group, because we see many of these patients. So it's a very common problem. Often they develop hypertension, that is more common than anything else, but also we see evidence of proteinuria and renal disease in these patients. And so these are some of the agents that we use now. The first one that was more commonly used, or still in use at our institution, is the use of bevacizumab, but now there is also the anti-VEGF-R2 antibody. There are also the VEGF trap-soluble decoy receptor binding VEGF, and also TKIs. And so TKIs are used right and left. It looks at every week there is a new TKI. And what they have in common is that many of them have kidney side effects, and sometimes, at least here, we have sometimes patients in a clinical trial. The name of the medication is ML2345. We don't even know what it is. We know that it's a tyrosine kinase. And then all of a sudden, we realize that we're having kidney effects, in particular hypertension, but also evidence of proteinuria and glomerular disease. And And so the most commonly observed findings in pathology with the use of VEGF antagonists, we see a lot of TMA. I mean, TMA is super common. And also we can see minimal change disease and FSG-like. We used to biopsy everybody that presented with a presentation consistent with TMA. We say, okay, you need a biopsy, we need to find out. We don't do that much anymore. If the clinical presentation is consistent with that, we don't biopsy. Now, if it's not, then we do, and then because maybe the patient has something completely different. But TMA is by far still more common. Proteinuria, hypertension is common, and bevacizumab is the most likely associated with TMA. It's still in use in some specific cases, and for some patients, it's still, for example, for some of the GU cancer, still they use a lot of bevacizumab. But for example, for kidney cancer, they use quite a bit more the TKIs. Hypertension, like I said, is a common feature. And the proteinuria is variable, but sometimes can be in the nephrotic range. And sometimes there are changes consistent with FSGS in the cases of TMA. Now, one of the things is, what do we do with these patients, you know? And so it's a challenge, you know what I mean? And we want the patients to continue receiving therapy if we can. But sometimes if the proteinuria is very severe or the patient is having significant impairment of kidney function, we can't. There are some guidelines from ASCO that suggest, like, after 2 grams, we need to stop, or they need to stop the TKI or the anti-VEGF therapy. But the evidence for that is still kind of opinion-based. Our institution, we are doing now a clinical study looking into that to see whether or not really the proteinuria is linked to any different outcome, especially because we want these patients to benefit from the therapy they're receiving for their cancer. And so in terms of management for these patients, what is recommended, I mean, again, for the oncologist, before starting therapy, they need to really assess kidney function and UA. Something that happens at MSK is that sometimes, yes, they do a basic metabolic panel, but sometimes they forget the UA. And so sometimes we don't know what the proteinuria levels were to begin with. And again, these patients need frequent follow-up and to assess kidney function as well as proteinuria. And if the patient develops the proteinuria, so in coordination with the oncologist, they can consider dose modification in case of significant proteinuria, and talk to the oncologist to decide what is the best strategy for the patient. Again, we want the patients to be able to continue therapy. Often on our end, what we do is say, we give them diuretics to help with edema. We give them diet recommendations. We recommend ACE inhibitors or ARBs to help with the proteinuria, and of course, a patient education. What we have seen, and I don't know what is the experience of others, is that in our hands, the ACE inhibitors help, but not as much as we see with other conditions, such as, let's say, diabetes, for example, because we see a more significant decline. In these patients, often doesn't work all that well. There is some evidence that some of the mechanisms are endothelin mediated, and so maybe endothelin blockers may be a better strategy, but we don't use them yet, you know. But again, this is a very common situation in our practice. Another big one for us is the chemotherapy-associated glomerular disease. And some chemotherapies are commonly linked to proteinuria. For example, one of the big ones is gemcitabine. This is one case from our institution, a patient with a cholangiocarcinoma who are receiving gemcitabine, developed new onset hypertension, edemas, evidence of hemolysis and acute kidney injury, a rising creatinine, anemia, low platelets, schistocyte. Really, I mean, a clear case of TMA. For this particular patient, what was done was supportive care, stopped gemcitabine, and 6 months follow-up, the creatinine was back to normal, and the patient was doing well. And so basically, gemcitabine is a pyrimidine analog used for a variety of solid tumors, and its use is linked to TMA. The initial incidence was pretty low, but we see it actually more close to 2%. So we see it. I mean, we don't see it in every single patient who is on gemcitabine, but we see it. At our institution, so we reviewed 29 cases of TME associated with gemcitabine by Ilya Gleserman. This patient had a median age of 64, 18 were women. There was the dose of gemcitabine they were getting, duration of therapy 2 to 34 months. And basically, this patient had significant anemia, low haptoglobin, high LDH, schistocytes. Patients, not all of them got a biopsy, 4 of them had a biopsy consistent with TMA, and the hypertension was common, and the CHF in 7 patients, and edema in 21 patients. And so basically, these patients, when we stop therapy, most of these patients do well. However, there are cases in which there is not full recovery, and there are a few patients who end up on dialysis. And plasmapheresis, I don't think that there is an indication for plasmapheresis, and we don't do it at our institution for gemcitabine-induced TMA because the evidence for that is not clear. And really, the life expectancy for gemcitabine is between, at least in our city, between 1 and 65 months. One patient died due to the TMA and hypertension. Again, many of these patients have very advanced cancers, and they die from their malignancy, but not really related to the TMA or the hypertension. And the one question that comes up all the time, how about eculizumab? And really, at other institutions, in the case of drug-induced kind of TMA, they use they try to use eculizumab, and the evidence for that is very soft, really, and really, if you look at these patients on eculizumab versus non-eculizumab, and really there is not a lot of difference in outcome. Maybe the patients who receive eculizumab have a better hemoglobin, but other than that, really there is not a lot of difference, in terms of kidney outcomes, how many end up on dialysis, etc. Really is not. So basically, what I'm trying to say is that at our institution, for drug-induced TMA, we do not use eculizumab. In some cases, somebody had used it kind of in a desperate measure and whatever, and really didn't make any difference. And there is a paper, it's not from our institution, but basically comparing eculizumab versus control and retrospective analysis. And basically, although it looked that the GFR was a little bit higher, really there is a lot of overlap. So it's very hard to tell whether or not it is better. I don't think it is. And maybe the anemia is better, in terms of the patients receiving eculizumab, have less anemia and receive less transfusion, but other than that, from the kidney outcomes point of view, there is no huge difference. And so basically, for these patients, what we do at our institution, and it worked well for us, is to stop gemcitabine. There is no question. We have to stop it. And talk to your oncology team to decide what is next, because patients cannot be on gemcitabine anymore. Give the patients platelets as needed, as well as a transfusion if needed, and monitor kidney function closely and involve nephrology, of course, if there is significant renal dysfunction, and adjust fluids based on renal status. And from the cancer point of view, consider other alternative therapy for the specific cancer they're having. So in summary, treatment-induced glomerular diseases such as proteinuria, TMA, nephropathy, minimal change disease, and post-transplant proteinuria are significant challenges in cancer care. And I think that one message for the group is that early detection, follow-up, and tailored management are essential to improve the quality of care and patient outcomes in the patient population. And with this, I'm going to stop my presentation, and I'll be happy to take any questions that the group may have. Thank you.
Thanks very much, Prof, for sharing your insights and a very complicated field that many of us are struggling with. And there's a whole range of questions on the chat. So perhaps if we don't get to them all, because we are running out of time, that you might be able to answer some of these for our audience. But I'll just pick up on a couple of them. So the first question was really about case 1, and I also had a question about that, and that was the thymoma case. And for you, was that the thymoma that caused the disease, or do you think it was the treatment and the kidney disease? And the person who asked the question says the thymoma and nephrotic syndrome, would you not repeat the CT whole body? So I think what they're asking is the same thing. Do you think it's the thymoma or the treatment?
Yeah. Well, for that particular case, our interpretation was that probably was the thymoma, but we were not really sure, you know what I mean? It could have been also the treatment, you know what I mean? But we went along with the idea, well, maybe it was the thymoma, you know, but it was difficult to prove definitely, you know what I mean? But it could have been the treatment too. But our interpretation and working with the oncologist, we consider most likely was the thymoma.
Thank you. And then there's quite a few questions about membranous and phospholipase A2 receptor positivity. I think what I'd like you to try and do is maybe just summarize. So the question actually says, in patients with cancer and proteinuria with positive antiphospholipase A2 and membranous, do you treat as primary or secondary? I know you had an algorithm there. Or sort of what is your personal approach, and when do you start screening for other membranous nephropathy antigens? Just try and sort of summarize the complications.
Yeah, that is a great question. It's something that we struggle with as well. And so now we see, again, we are at the cancer center. So we see the bulk of our patients with membranous are secondary membranous. However, we have seen also patients who come with a cancer and a membranous that is PLA2R positive, you know what I mean? And so in that case, we assume that is primary, you know, and we go with that, you know what I mean? And we see those patients, and that's what we do, you know, and so we say, okay, this looks like primary, the PLA2R is positive. Yes, the patient has a cancer, but the membranous has nothing to do with it, you know what I mean? Now, it's not a, for us, it's not a common scenario, you know, but we have had that situation in a few cases. We are doing PLA2R on all our patients. That's something that we do, and so our renal pathology is not read at MSK, because our pathologists are cancer pathologists, you know what I mean? And so what they can say is, oh, you send a kidney biopsy to our pathologist, say, oh, there is no cancer here. But that's not what we need. And so they go to Cornell. And so at Cornell, they do the benign renal pathology. They do and the PLA2R can be done there. But also for the blood, what we do, we send them to Mayo. But that is kind of the basic one that we are doing. We are not using FAT1 quite yet, you know what I mean? And again, seems to be related to allo transplant, you know, so if we have a patient with allo transplant, I think the FAT1 is giving us insights about pathogenesis, you know, maybe, but if we see a patient with membranous after allo transplant, and especially the patient is off prophylaxis for GVHD, so we put them back on immunosuppression, you know, that's kind of what we do. If the patient has something consistent with membranous, we give him, like for membranous, you know what I mean? I have a patient, the mentioned that one before, we put on rituximab and she's doing fine, but it was an allo transplant, you know, so that's kind of what we do. But again, if the PLA2R is positive, we treat it as a primary. Yeah.
Perfect. Thanks for that. I think it's a bit complicated. I'm going to try, as my final question, wrap up a couple of the questions that are in the chat together. And that is in the case of multiple myeloma and the role, how important do you feel is the renal biopsy, particularly when you've got a low GFR, particularly when there's resource constraints, and you've had a bone marrow biopsy? What is your feeling about sort of doing a renal biopsy? And also, I guess, how important is it following that as an indicator or usefulness for stem cell transplantation? So that's sort of incorporating a couple of questions together. I hope I did that okay.
Oh, those are wonderful questions. And that is one of those that we scratch our heads all the time because are difficult questions. Yeah. So basically, now, just to give you a little bit of feedback on that, something that we are doing right now, but we don't have the data completed yet. We are analyzing that data. So what we are doing right now is we are reviewing all the biopsies of patients with myeloma, kidney biopsies, and trying to assess whether or not that biopsy is really helping outcomes in those patients, you know what I mean, in terms of whether or not the biopsy did help to decide on therapy or outcomes, et cetera, et cetera. Now, something that we do for patients with myeloma is that if there is significant proteinuria, and especially we want to rule out amyloid, we may do a biopsy, not all the time, but usually we do. We have had also patients with amyloid in which the kidney biopsy was the one that gave the diagnosis, you know what I mean? And so the oncologists struggle with that. We check this, we check that, and it's not, the criteria are not there. Please, and then we do a biopsy, and that's where we see the money, you know what I mean? And so I think it's important. We don't do a biopsy in every single patient, basically we don't have like a clear algorithm to doing biopsies in myeloma. Maybe we should, but we don't have it. Again, I hope that with the data that we are collecting now, and we're trying to analyze, well, we may have a better answer to that. We do it kind of on a case-by-case basis. I suspect that we should be doing more biopsies than we are not, and there is the sense, and I don't know what is the experience of the group, that patients with myeloma have a higher rate of complications after biopsy, and we have seen a couple of complications that they bleed more, etc. But again, that by itself should not be a reason not to do it. But we don't have a clear algorithm for that, except in the presence of proteinuria. Yes, we do. For transplant, many of our patients receive an auto transplant, and the large majority of them, and the majority of them do not get a biopsy, you know what I mean, and kidney biopsy, I mean. So, but I don't know, we're talking about allo, it's a little bit different. Many of these patients now are getting a CAR T-cell therapy, but that is a completely different story, So, but again, we are not, again, to answer your question, we are not biopsying everyone, and maybe we should be biopsying more of these patients.
Thank you very much. I think that was a fantastic answer and helped me with answering quite a few of the questions on the chat. Unfortunately, we've run out of time, but we're just incredibly grateful for you sharing your experience. I think these questions are difficult. Understanding the new drugs are very difficult. Some of us, or many of us on this call, don't have a lot of access to some of the newer drugs. So they may come, and having people having the experience and sharing with us is really very, very important for us. So I'm just going to thank you. I'm going to thank our other panelists for their time and their contribution. I want to thank Rasha and Amir for us putting together the World Kidney Academy, which I'm actually very proud to be part of. And I encourage people to learn from the Academy. The GN course is really a fantastic interactive course that I feel very proud to be part of. So I don't know whether anyone else, Rasha, whether you'd like to say the final word, but I'm grateful to be here.
Thank you so much, Nicci. Thanks, Dr. James, for the excellent talk. And thanks, Dr. Saddam, for the excellent moderation. Thanks, Yara, for the interesting case, Dr. Amr, and everyone. Thanks for the audience. Thank you so much. Stay tuned and mark your calendar for the coming webinars. Thank you.
Thank
Goodbye.
you. Bye.